Good afternoon. Welcome to Regional Distance Learning Clinical Seminar Series. Today's topic is Guidelines for the Management of HIV Associated Malignancies and speaker Dr. Ravinder Kaur Sachdeva. Dr. Ravinder is currently working as a Senior Medical Officer at ART Center and COE Chandigarh. She was associated with WHO for strengthening of routine immunization and surveillance for vaccine preventable diseases. She has published more than 26 papers in international and national indexed scientific journals of high impact and more than 705 citations. Now I request Dr. Ravinder to start the session. Thank you.
Hello, thank you Sonia for the introduction. So today I'll be discussing on the guidelines for the management of HIV associated malignancies. There are a group of entities which have been listed in this session. So I'll be describing these one by one. Next, please. So, HIV is associated with an increased risk of for many malignancies. The term HIV-associated cancer is used to describe the larger group of cancers, which are both AIDS-defining and non-AIDS-defining cancers, which have an increased incidence among patients with HIV infection. In addition, there are incidental cancers which also develop in patients with HIV infection. So, as the ACE definition is crystallized, Kaposi sarcoma, high-grade B-cell non-Hodgkin's lymphoma, and invasive cervical cancers, these have been designated as ACE-defining malignancies. Cancers account for approximately one-third of all deaths in HIV patients. And HIV patients, they have a higher risk to die from a tumor than from an AIDS-related infection, with aggressive non-Hodgkin's B lymphoma as the most frequent event. Next, please. So now I'll be discussing about the Kaposi sarcoma. It's a multicentric tumor which is characterized by lesions ranging from a few indolent skin lesions to multiple lesions which involve one or more organs, especially the oral mucosa, GI tract, lymph nodes, lungs, and bones. It's caused by Kaposi sarcoma herpes virus, and lesions appear most often on the lower extremities, face, genitalia, with hues including pink, red, purple, and the brown hue. Next, please. The diagnosis is usually based on the characteristic clinical appearance of cutaneous or mucosal lesions, but histological confirmation is required. There's extracutaneous spread, which is seen in one-third, with oral cavity involvement seen in 15% of individuals, and GI tract involvement 40%, and pulmonary lymph node involvement is also there. Occult blood in the stool is an excellent screening modality, and a cherry red nodule on bronchoscopy is strongly suggestive of the diagnosis of Kaposi sarcoma. To stage, histopathological grading classifies Kaposi sarcoma into patch, plaque, or a nodule. Risk stratification is based on tumor stage, which can be T0 to T1, immune status 0 or 1, and systemic illness. Staging of Kaposi sarcoma includes a complete inspection, which includes oral and genital mucous membrane inspection, abdominal ultrasound, chest radiography. Gastroduodenoscopy and colonoscopy should also be considered when there is mucous membrane involvement. So there's to grade the tumor. There's for the staging. The tumor is categorized as a good risk tumor when it is a localized only in the skin or lymph nodes, and there's a small amount of disease or small amount of disease is seen on the palate. The lesion in the mouth, if these are present, these are flat rather than the raised, then it is categorized as T0 or the localized tumor or a good risk tumor. And it will be categorized as a poor risk when there is associated edema, extensive oral lesions which are nodular, raised, and lesion of the Kaposi sarcoma seen in the organs other than the lymph nodes like lungs, intestine. And Kaposi sarcoma in the lungs can sometimes means a worse prognosis also. And then this is a T1 stage. Next, please. Immune status 0 or the good risk is when the CD4 count is more than 150, and if the counts are less than 150, this is categorized as a poor risk. Systemic illness involvement, if there is no systemic illness involvement, like there are no history of opportunistic infections, or there are no B symptoms which are unexplained fever, night sweats, weight loss of more than 10%, or there's a canoscape performance status score of 70 or higher, this will be the good risk S0. And it will be categorized as a poor risk if there is history of opportunistic infection or thrush or presence of one or more B symptoms and KPS score of under 70, and there are other HIV related illnesses present. Next, please. So to treat, local therapies is useful for localized bulky Kaposi sarcoma lesion or for cosmetic reasons, but it does not affect the development of new lesion in the untreated areas. Alitretinoin gel is the only topical self-administered therapy which is approved for the treatment of Kaposi. Patients require 4 to 8 weeks for clinical benefit, and dermal irritation appears to be the most common adverse effect with this. Sometimes in the dark skin patients, it is also seen as an this undesirable skin lightening after the use of this gel. And alternative local treatments include intralesional chemotherapy, radiation therapy, local therapy, and cryotherapy. Vinblastine is recommended as the only alternative local therapy with an excellent response rate of 70%. Next, please. In the systemic therapy, sorry, next, please. Liposomal doxorubicin or liposomal daunorubicin are recommended as the first-line chemotherapeutic agents, and it is not recommended to use interferon therapy for Kaposi sarcoma lesion in view of poor treatment, poor tumor response, and drug toxicity. Next, please. So this diagram shows the lesions before treatment of lesion before treatment and after the treatment. You can see the ulcerative nodular lesion in the oral cavity, which has actually shown the massive improvement after the treatment. Next, please. So the recommendations are local radiotherapy or intralesional vinblastine for symptomatic or cosmetic improvement is recommended in the early stage. Chemotherapy along with the antiretroviral therapy for T1 advanced stage Kaposi sarcoma. Liposomal anthracyclines are recommended as first-line chemotherapy for T1 advanced Kaposi sarcoma. Paclitaxel for second line treatment of anthracycline. Refractory Kaposi is recommended. So now a few words about the AIDS-related non-Hodgkin's lymphoma. PLHIVs, these have an increased risk of developing non-Hodgkin's lymphoma, diffuse large B-cell lymphoma, and Burkitt's lymphoma. These are considered as AIDS-defining illnesses. And despite the decrease in the incidence of AIDS-related lymphomas with increasing ART use, these lymphomas have increased as a percentage of first AIDS-defining illnesses. The development of age-related lymphoma is characterized by advanced clinical stage, presence of B symptoms, extranodal involvement, which includes bone marrow infiltration, and it has been shown to be related to older age, lower CD4 cell count, and no prior treatment with antiretroviral therapy. Lymphomas also occur in the immunocompetent patients, and these are usually Burkitt's, diffuse large B-cell lymphomas, Hodgkin's lymphomas, and other lymphomas which are mild or peripheral T cell and NK cell lymphomas. The lymphomas which occur more specifically in HIV patients are the primary fusion lymphomas, plasmablastic lymphomas, lymphomas occurring in HHV8 associated multicentric Castleman disease, and lymphomas occurring in other immunodeficient states. And it can be the post-transplant lymphoproliferative disorder. Next. So this patient presented with multiple bilateral non-tender and firm lymph nodes in the cervical region, and mediastinal widening was also seen on the X-ray. And CT abdomen also showed the presence of multiple nodes in the left aortic and aortocaval regions, with a small rounded hypodense lesion in the anterior respective upper pole of right and the mid pole of left kidney also. And there were lymphomatous deposits with minimal left pleural effusion, and the further diagnosis of non-Hodgkin's lymphoma was made in this individual. Next, please. So apart from the usual blood test to diagnose this condition, the evaluation and clinical staging of lymphoma requires CT imaging, bone marrow aspiration, and bone marrow trephine biopsy. PET scan was also done at the time of diagnosis so as to get the staging accuracy. CSF examination was also done so as to see the involvement of the CNS or paranasal sinuses. If there are clinical signs of CNS involvement, paranasal sinuses, breast, epidural, or testicular involvement, CSF examination is also done in such individuals. And whenever a patient develops these symptoms and signs while on antiretroviral therapy, virological testing is advisable so as to rule out the virological failure, as it's an age-defining malignancy. Next, please. So there are viruses which are associated with this lymphomas, like the DLBCL, Burkitt's, primary infusion lymphomas, primary CNS lymphoma, plasmablastic, and Hodgkin's lymphomas. These are associated with the Epstein-Barr viruses, and frequency varies in various categories. Multicentric Castleman disease is associated with the HHV8 virus in almost all cases. Next, please. So in the diffuse large BCL is the most frequent age-rated lymphoma, and it often presents at an advanced stage with B symptoms, and there can be extranodal tissue involvement as well, and is mainly seen in the severely immunosuppressed patients. And prognosis of DLBCL is determined by patient lymphoma and other HIV associated factors. IPI scoring, IPI index has been extensively validated and remains a reliable predictor of outcomes in DLBCL. Low CD4 counts, it has been reported to the predictor of poor survival in several studies. It has been proven that people who have lower CD4 counts, they actually go for a very kind of a poor survival. So we all know that ART has led to the better immune reconstitution and hematopoietic growth factors. These have allowed the use of conventional myelotoxic chemotherapy, and the first line chemotherapy is being as per the recommendation by the hematologist or oncologist, and these therapy options are being decided once this diagnosis is being made. These are actually linked with the specialty clinic for further diagnosis and the management, and dose adjustment is being done as per the neutrophil counts and other hematological parameters. Next, please. So if it's a localized disease, it is usually refers to the patient with the stage 1 disease of DLBCL, and it should be treated with the combination modality treatment with chemotherapy, and or it is being followed by the radiotherapy, which this treatment protocol is being decided by the hematologist slash the oncologist. And if this disseminated disease is there, again, and the advisable first line regimen is being given to the patients. Minimum 6 cycles are being given, and addition of rituximab to chemotherapy and is actually being routinely being recommended for DLBCL. And for a relapse or the refractory diseases, treatment options are actually being poorly investigated, and high dose salvage therapy is further decided based upon the relapse or if it is a refractory case. And patients who are with the chemosensitive disease who are eligible for transplant, these are also options of autologous stem cell transplant. Stem cell transplantation is also being discussed with the patients by hematologists. So we call a complete response when there is complete clinical and radiological disappearance of disease as per the PET is negative in these individuals. And yeah, for the partial response in the DLBCL, it is when the patient has more than 50% or almost 50% decrease in the diameter um, uh, of the larger dominant masses, and there is PET positivity seen in these cases. And a stable disease of for DLBCL is when there is a failure to attain complete response or the partial response, and relapse or the refractory disease is any new lesion which is there, or the increase in the size of lesion by more than 50% of a previously involved site. So recommendation in DLBCL is the chemotherapy, R-CHOP, and the other therapies as decided for the DLBCL. Chemotherapy should be combined with the antiretroviral therapy, and a closer surveillance is mandated for those who have CD4 count of less than 50 cells. And patients with the relapse or the refractory disease should proceed to the autologous stem cell transplantation after the high dose therapy. The options are being discussed with the patients for this, and the PET scan should be performed at the end and after 4 to 6 weeks of therapy. Now for Burkitt's lymphoma is the second most common subtype of age-related lymphoma, which occur in individuals with relatively preserved CD4 cell count. Poor performance status and high LDH are the other can be seen in these cases. There can be extranodal involvement, and the incidence of CNS involvement ranges from 8 to 28%. And the most widely used regimen for Burkitt's lymphoma and other chemotherapy, this is all being decided by the hematologist at our point of level. Like when we see such cases, we should be able to actually pick up those clinchers when the patient present to us with any of these features. Like this diagnosis should not be missed. Like if the hemograms and other lymph node involvement is seen in the cases, or there is a some mass, abdominal mass is seen, we should be able to diagnose such cases, and we should be actually able to link such cases as early as possible with the concerned department, so that further treatment protocol can be decided, and they should be put on the chemotherapy as soon as possible. Next, please. So the risk stratification for treatment of Burkitt's lymphoma is it is low risk disease when there is normal LDH levels, or there is stage 1 or 2 disease, or there is the WHO performance score of 0 to 1, and the number of extranodal sites are less than or equal to 1. And at least 3 of these factors should be there in the case, so as to categorize this as a low risk disease. And presence of high LDH levels, stage 3 or 4 disease, and WHO performance score of 2 to 4 with a extranodal site of more than one extranodal sites involvement, and is categorized as a high risk disease when there are presence of 2 or more of such factors. So the chemotherapy as a first line for Burkitt's lymphoma, and the regime should be combined with the antiretroviral therapy. So the prevention of for the prevention of secondary CNS lymphoma, there is a use of intrathecal prophylaxis with methotrexate. It has been actually been considered a mandatory part of systemic treatment of all HIV patients with aggressive non-Hodgkin's lymphoma. And advanced stage, elevated LDH levels, extranodal disease, and involvement of testicular lesions, paranasal sinuses, paraspinal location, or involvement of breast, renal, epidural space, and bone, it predicts a high likelihood of CNS relapse. CNS prophylaxis should be reserved for those who need it based on the site of its involvement, stage, and histological subtypings. And all patients with diffuse large BCL, they should receive CNS prophylaxis, intrathecal or intravenous. And all patients with Burkitt's lymphoma should also receive CNS prophylaxis. Next, please. So patients at high risk of developing tumor lysis syndrome, and this actually those with the DLBCL, those patients with DLBCL elevated LDH level, but or those who have bulky disease, and those with Burkitt's lymphoma with stage 3 or 4 disease. Uh, this and they are seen the group of metabolic abnormalities which occur as a complication of treatment of these malignancies, and where large amount of actually tumor cells are killed off from the treatment, and which release the contents into the bloodstream. And this is usually seen when we are treating such malignancies. And aggressive treatment to prevent tumor lysis syndrome is it includes adequate intravenous hydration and raspiuricase. And the first dose is to be administered 4 to 24 hours before starting chemotherapy, and is given as intravenous infusion over 30 minutes, and it should not be given as a bolus dose. So actually a repeated dose should be used if the serum uric acid are above 7 milligrams. And those who do not meet the criteria for high risk disease should also be adequately hydrated, although oral hydration and allopurinol, these are usually being given. So it's actually a fatal complication, and patients at increased risk of tumor lysis syndrome should be closely monitored while receiving chemotherapy, and they should also actually receive preventive measures and treatment as and when required. So for the relapse or the refractory age-related lymphomas, in the absence of any standard second-line chemotherapy regimen, there's various aggressive regimens which mostly contain platinum. These have been tried, and commonly used include dexamethasone, cytarabine, cisplatin, ifosfamide, cisplatin, and etoposide. So this is actually usually combined with rituximab, and this is actually this treatment protocol for the first treatment protocol, and even for the relapse or the refractory case, is being decided by the hematologist. And for those who respond with the therapy, or the option of the stem cell transplantation if it is required, this is being discussed with the patient as per the response of the patient while being given the chemotherapeutic agents. Next, please. So in the primary CNS lymphoma, uh, next, please. So it's a subtype of the diffuse large cell B cell lymphoma with a post-terminal center phenotype, which is confined to the craniospinal axis without systemic involvement. It can affect any part of the brain, leptomeninges, cranial nerves, eyes, or spinal cord. And presentation varies from subacute focal lesion in 50% to the neuropsychiatric signs presence, or there can be the increased intracranial pressure, or there can be a presence of the ocular symptoms. To raise serum LDH level, CSF analysis is done, and brain biopsy is required to establish the diagnosis. And diagnostic algorithm for management of cerebral mass lesion in HIV patients, this also includes a 2-week trial of anti-toxoplasma therapy, and detectable EBV virus in the CSF, and consistent radiological findings in immunosuppressed patients. These are sufficient to make the diagnosis. MRI is actually the most sensitive imaging modality to establish the diagnosis. There can be the non-enhanced T1 weighted images, hyperintense tumor findings, edema surrounding, and there can be densely enhancing masses after administration of the gadolinium. So HIV positive patients with primary CNS lymphoma usually have advanced immunosuppression, and the counts are usually less than 50, which is actually makes the possibility of the administration of methotrexate and cytosine as a chemotherapeutic agent kind of impossible in such situation when they have advanced disease. High dose methotrexate and rituximabs, these appears to be the alternative. And if induction treatment is well tolerated and response is documented, then consolidation with high dose therapy and stem cell transplantation, if it is being required, should be considered in the selected patients. And high dose methotrexate containing chemotherapy regimen is being recommended, and combination with antiretroviral therapy is advisable. Recommendation of whole brain radiotherapy is a palliative treatment modality, which is being considered if the treatment options fails. Next, please. In the primary fusion lymphoma, it's a rare B-cell lymphoma which is characterized by effusions involving pleura, pericardium, and peritoneum without identifiable tumor masses or lymphadenopathy. There is severe immunosuppression with the low CD4 count, and HHV8 is associated with in almost 100% of cases. Patient can present with dyspnea because of pleural and the pericardial involvement or abdominal distension from the peritoneal involvement. And to diagnose, cytological analysis of the effusion fluid is done, and detection of the evidence of the viral infection is actually being done to make the diagnosis. Immunohistochemical staining for latency associated nuclear antigen expression is a standard for detecting HHV8 in tumor samples. In the absence of any standard treatment, primary fusion lymphoma in HIV should be treated with the CHOP regimen, and such treatment should be included as part of the clinical trial if possible, and ART should be administered concurrently with such treatment. The plasmablastic lymphoma is a rare variant of diffuse large B-cell lymphoma with plasmacytoid appearance, which affects primarily mucosal sites of oropharynx in males. And there are three histological subtypes, which includes monomorphic plasmablasts with minimal plasmacytic differentiation, which predominantly affects the oral cavity, and those with the more plasmacytic differentiation involving extraoral sites. And the third one is the plasmablastic lymphoma, which involving nodes or spleen or associated with the Kesselman's disease. IHC positivity for plasma cell markers, CD38, multiple myeloma, oncogene MAM1, and CD138 is being done. The constant presence of EBV is considered as a diagnostic. The absent expression of leukocyte common antigen, that is CD45, or B cell markers CD20, CD79A, and PAX5. This serves to distinguish plasmablastic lymphoma from immunoblastic variant of diffuse large BCL, body and extra cavity variants of plasma lymphoma with plasmacytoid differentiation and extramedullary plasmablastic secondary multiple myeloma is being done. So the treatment is again being decided by the hematologist or oncologist as per the protocol. So CHOP-like treatment, these have been as the standard of care, but due to the disappointing survival rates and more intensive regimens are being introduced. And plasmablastic lymphoma should be treated with the intensive chemotherapy followed by radiotherapy, at least in the localized stage, and early consolidation with the stem cell therapy may be the option for the advanced stage patients, and ART should be concurrently used. Now, amongst the cervical neoplasias and cervical cancers. So cervical cancers in HIV patients, this is an actually in is common in HIV patient with an earlier age of diagnosis, and this is actually associated with aggressive course and poor treatment outcome if not treated timely. And cervicovaginal HPV infection, it has been reported to be higher in HIV positive women than in HIV negative counterparts. And ART has had minimal effect on the incidence of invasive cervical cancers, but it has effectively brought down the incidence of cervical intraepithelial neoplasias in women who are infected with the HIV. So this is the diagnostic algorithm of cervical cancer screening in India, which is actually the initial screening at the health center is by the visual inspection acetylacetic acid. If this is positive or negative, if it is a negative, then the repeat screening is being done after 5 years, and proper patient is being educated for the proper hygiene and all. And if the VIA test is positive, we refer such patient to the district hospital where the PAP screening is being done, and followed by colposcopy to stage whether it is a CIN on colposcopy. And if it is localized, if it is suitable for cryotherapy, and which is being done after punch biopsy. And if the lesions are not suitable for cryotherapy, then the patient is being referred for the LEAP therapy. Uh, and which is then followed up after 1 month with the PAP and the biopsy report. If the report shows malignancy, then the patient is being referred to the medical college or the center for the treatment. And if it is being treated for cervical intraepithelial neoplasias, we followed up after a year for a repeat PAP and colposcopy. If colposcopy is normal for such patient, PAP is showing the low-grade squamous intraepithelial lesion, again patient is being followed up after a year. And if the colposcopy is normal, PAP showing the high-grade squamous intraepithelial lesion, a repeat colpo and a punch biopsy is advisable to such patients. And further treatment plan is done. If the biopsy is positive for malignant cells, then the LEAP or the cryotherapy is being done. If it is negative, then if the biopsy is negative, again a repeat test is being done after the 5 years of this particular test. So again, this is if the VIA test is positive, as I have just mentioned, then the patient is being advised to go for a colposcopy. If the colposcopy is normal, or if the colposcopy is positive, further treatment is decided on that. If the colposcopy is showing the lesions, then the patient we decide for, but we actually it is being decided whether the patient is suitable for cryotherapy or not suitable for cryotherapy. If cryotherapy is being done, it is well and fine. Follow up after a month. If it is not done, then the LEAP is being advised to such patient. And further, if it is normal, the repeat test is being done after 5 years of this particular test. So again, this is again, as I have already explained, if the follow-up after a month is showing malignancy, or then on biopsy, such patient is being referred to the medical college for further management. If the follow-up after a month with PAP and biopsy is showing the cervical intraepithelial lesions, neoplasia lesion, this is being followed up after 1 year and at the district hospital by PAP and the colposcopy examination. If the colposcopy is normal, or perhaps is showing the LCL lesions, again it is similar management is being done, that the patient is being followed up after 1 year again. And if colposcopy is normal, PAP is showing axial lesions, repeat colposcopy and punch biopsy is being done. And if biopsy is positive, again the therapy is would be the treatment would be the LEAP or the cryotherapy would be done. If biopsy is negative and colposcopy is normal, again patient is being followed after 5 years of this particular examination. So HPV 16 and HPV 18, these are actually associated with the CINs, and these encodes for three oncoproteins E5, E6, and E7, which stimulate the growth and have transforming properties. And the integration of HPV DNA within the host genome, it results in the chromosomal instability and favors the progression from CIN to invasive carcinoma. And HIV mediated immunosuppression, it prevents the clearance of the HPV, which is present if it is there, which leads to the gradual loss of control over HPV replication. And there are now actually three major alternatives for cervical cancer screening: cytology, HPV testing, and cytology HPV co-testing. So treatment includes surgery, radiotherapy, and chemotherapy. Surgery includes for invasive carcinoma. Surgery includes radical hysterectomy and lymphadenectomy, which is an important in the management of the early stage cervical cancers. And treatment of locally advanced cervical cancers include radiotherapy as well, and chemotherapy. So the recommendations are: screening cytology for HIV positive women is recommended at the time of diagnosis, annually thereafter, and if 3 annual pap smears are negative, it should be done every third year. And colposcopy should be performed if abnormalities are seen on the pap screening. And the treatment of CIN or invasive cervical cancer, it should follow the same guidelines as those advocated for the HIV negative population. For anal cancers, the incidence in PLHIV is up to 40 times higher as compared to the general population, and it occurs at a much younger age, with the highest risk in men who have sex with the men. And anal cancer can present with rectal bleeding, anal pain, incontinence if anal sphincter is affected. And pathogenesis, it resembles that of cervical cancer with HPV, leading to anal intraepithelial neoplasia and ensuing progression from the low to high grade dysplasias and subsequently invasive carcinoma. So again, grading is being done for anal intraepithelial neoplasias, which is grade 1 to 3 if it is involving lower third, lower two-third, or entire epithelium. And cytological grade are from the low grade squamous intraepithelial lesion to the high grade squamous intraepithelial lesion, and as grading 1, 2, and 3. So as per the Bethesda system, the classification will be N normal, asks if it is atypical squamous intraepithelial cells of undetermined significance, is as H, atypical squamous cells which cannot exclude high-grade squamous intraepithelial lesion, and LCL as a low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion, and then cervical squamous cell carcinoma. So primarily surgery has nowadays been replaced by the concomitant chemoradiotherapy, and which achieves a local control and sphincter preservation in the anal carcinoma. Primary tumor resection is restricted to small tumors of the anal margin, and concomitant chemoradiotherapy in HIV patients should be performed according to the current guidelines for the non-infective individual. And intensive modulated radiation therapy or volumetric modulated arc therapy with the stage adapted dose is combined with chemotherapy, and this again is being decided by the surgeons who or the oncologists who are performing who are actually being treating these patients. And because of the nephrotoxic potential of the mitomycin, tenofovir should be used with caution in such individuals, and zidovudine should be avoided in view of possible bone marrow toxicity. So to monitor these individuals, the response to chemotherapeutic agent should be assessed at 6 to 8 weeks after completion of therapy, with clinical evaluation, MRI imaging, and examination under anesthesia. Clinical evaluation and review should continue every 3 to 6 months for 2 years, and then every 6 to 12 months for up to 5 years. For any residual primary disease or local recurrence after chemotherapy, it demands salvage therapy, which involves abdominal perineal resection of rectum and anal canal. And patient with metastatic disease or local relapse, this follows salvage therapy, may be considered for palliative chemotherapy. So all suspected cases of anal carcinoma should have examination under anesthesia and biopsy. Imaging, CT and MRI should be performed to assess the lymph nodal involvement and tumor extension. And high resolution endoscopy services should be available for surveillance of these carcinomas. And chemotherapeutic agents, fluorouracil and mitomycin is the first line treatment. Salvage therapy should be advised for loco-regional disease persistence or relapse, and best supportive care should be advised for metastatic disease or local relapse following salvage therapy. So now for the Hodgkin's lymphoma, it is one of the commonest tumor among the non-AIDS defining cancers. This is a 10 to 20-fold increased risk of incidence of Hodgkin's lymphoma in HIV patients as compared to the HIV negative population. And it occurs most commonly at a CD4 count of less than 200. The risk of developing Hodgkin's lymphomas remains while on ART, and Hodgkin's lymphoma incidence rates are higher in first few months after starting therapy. And viral load, it has not been shown to relate to the incidence rates for Hodgkin's lymphoma. So this characteristics of Hodgkin's lymphoma in HIV patients, it varies from the advanced stage at diagnosis. There can be more extranodal involvement, especially the bone marrow infiltration. There can be presence of higher frequency of B symptoms, or there is a poor performance status of such individuals in HIV infection. Next, please. So the diagnosis mandates tissue sample biopsy, Ann Arbor classification, Cotswolds modification. It requires blood test, whole body PET scan, and unilateral bone marrow biopsy. And staging is being done as per the involvement of the whether it is a single lymph node group or lymphoid structure, which is stage 1, and involvement of 2 or more lymph node groups on the same side of diaphragm is stage 2. Involvement of lymph nodes groups on both the side of diaphragm is stage 3, and extranodal sites involvement would be designated as stage 4. And X staging is for the bulky disease, which is more than 10 centimeter or more than one third widening of mediastinum is seen at T5 T6 level. And extranodal extension, contiguous or proximal to known nodal sites of disease or single isolated site of extranodal tissue is categorized as E stage. And A or B would be if there are absence or presence of B symptoms, which are more than 10% weight loss, fever, or drenching night sweats. So again, the chemotherapy modules are being decided by the hematologist for the management of Hodgkin's lymphoma, and this is being decided by the hematologist. Next, please. Whether it is chemotherapy alone followed by radiotherapy, this is again protocol is being decided accordingly. ABVD is a first line chemotherapy for Hodgkin's lymphomas to be administered in conjunction with the IFRT, and good performance patients with relapse or refractory, they should receive salvage chemotherapy. And if the disease proves to be chemosensitive, the treatment should be consolidated with the high dose therapy. Excuse me, or autologous stem cell rescue should be done. And ART should be co-administered during chemotherapy. And remember, PI based regimen should be avoided so as to minimize the additive toxicities like wind blasting mediated neurotoxicity, and neutropenia is also seen. And PCP, MAC, and fungal infection prophylaxis is recommended during and after chemotherapy for such cases. And assessment of response after treatment should be performed by PET scan and bone marrow biopsy. And follow-up should be performed every 2 to 4 months during the first 2 years, and every 3 to 6 months for further for further 3 years. So multicentric Castleman disease describes a group of at least four disorders that share spectrum of characteristic histopathological features, which have a wider range of etiologies, presentation, treatment, and outcomes. Excuse me. Multicentric Castleman disease is a relatively rare lymphoproliferative disorder that classically presents with fever, anemia, multifocal lymphadenopathy, and is now most diagnosed in individuals which is with who are with HIV infection. It presents with a generalized malaise, night sweats, rigors, fever, anorexia, and weight loss. Clinical examination reveals widespread lymphadenopathy, often with hepatosplenomegaly, ascites, edema, and pulmonary and pericardial effusions. Lab tests include reveals thrombocytopenia, anemia. There can be hypoalbuminemia and hypergamma-globulininemia. Excuse me. Next, please. So the classification, whether it is a unicentric or the multicentric Castleman disease, and the etiology, idiopathic or human herpes 8 virus involvement is there, or it can be seen with the associated with the other syndromes like with the poem syndrome, polyneuro, where there can be polyneuropathy, organomegaly, endocrinopathies, monoclonal plasma cell disorders, or skin changes, and idiopathic multicentric Castleman disease could be there, where we can have thrombocytopenia, ascites, reticulin fibrosis, and renal dysfunction or organomegaly can be seen. And the other classification is idiopathic multicentric Castleman disease, which is not otherwise specified. So diagnosis can only be established definitely by the lymph node biopsy, and features which are characteristic onion skin appearance and interfollicular plasma blasts which express HHV8 latent nuclear antigen. These plasma blasts also express high level of lambda light chain restricted immunoglobulin M, but are polyclonal and do not contain somatic mutation in their IgV genes. And occasionally, these plasmablasts join together to form clusters or microlymphomas, and these may progress to monoclonal plasmablastic lymphomas. And histological confirmation is required with immunocytochemical staining for HHV8 and IgM lambda is required. Elevated serum level of HHV8 always support the diagnosis of MCD. ART had no impact on the incidence or outcome of MCD in HIV. Rituximab based therapy has actually dramatically improved 5-year survival for HHV MCD from 33 to 90%. And rituximab is used as a single agent weekly for 4 weeks in patients with adequate performance status and with absence of hemophagocytic syndrome, hemolytic anemia, or end organ damage. The combination of rituximab and liposomal doxorubicin every third week appears to attenuate Kaposi sarcoma exacerbation in such individuals. And rituximab with or without etoposide appears to be effective in HHV8 MCD regardless of the HIV status. So recommendation for are that histological confirmation is required, and then monitoring for lymphoma is important in patients who are diagnosed with MCD. And rituximab is used as a first line chemotherapy agent. And retreatment with rituximab based therapy for relapse MCD is also there in the recommendations. And plasma HHV8 levels can predict relapse, and clinical monitoring for patients in remission should include measurement of HHV8 levels. Now for testicular germ cell tumors, seminomas and non-seminomas germ cell tumors, these occur more frequently in HIV infection, and irrespective of HIV status, a testicular mass must be treated with the utmost suspicion and ultrasound scan and tumor marker, which includes AFP and HCG levels, it should follow. And differential diagnosis for testicular mass in this setting includes orchitis and the lymphoma. CT, chest, abdomen, and pelvis should be performed for full staging for to categorize testicular germ cell tumors. So the secondaries can present as a cannonball masses in the, as it's seen in the lung fields in the in X-ray as well as in the CT image. So these are multiple pulmonary secondaries which are seen in the patients of which can be there in the patients of seminoma testis. Next, please. So, prognostic based staging system for metastatic germ cell cancers can be the good prognosis if non-seminomas, if there are testes or retroperitoneal primary or no non-pulmonary visceral metastasis is there, or AFP levels are less than 1000, HCG levels are less than 5000, and LDH levels are less than 1.5 times the upper limit of the normal, and these shows a 5-year survival of 92%. And seminomas, among seminoma, 90% of the cases, if any primary site, if there is any primary site, no non-pulmonary visceral metastasis, normal AFP, any HCG, and any LDH levels, the 5-year survival in such cases is the 86%. Next, please. So among the poor prognosis group, non-seminoma, presence of any of the following criteria of mediastinal primary, if it is there, non-pulmonary visceral metastasis and AFP levels are more than 10,000, SCG levels of more than 50,000, and LDH levels of more than 10 times the upper limit of normal, and 5-year survival for such cases is 48%. And in seminoma, there is no patient which is classified as a poor prognosis. So in the stage 1 disease, seminoma or non-seminoma germ cell tumors, it is only surveillance which is being done. For metastatic diseases, in a good risk patient, 3 cycles of standard chemotherapy with concurrent antiretroviral therapy and prophylactic antifungals is being advised. And patients with intermediate and poor risk disease, 4 cycles of chemotherapy. And for those who are with the extensive pulmonary limitations from previous infections, alternative chemotherapy is being advised. And for the relapse cases which are having 2 or more after 2 or more treatment regimens, high dose chemotherapy is being given, and this being followed by the autologous peripheral blood stem cell transplant, as in seen as we do in the HIV negative patients. Next, please. So surveillance may be considered for seminoma of testes as per the recommendations, and concomitant antiretroviral therapy and infection prophylaxis is advised during chemotherapy for testicular germ cell tumors. And this should be treated in identical manner regardless of HIV status. Bleomycin, it should be avoided in the patients in the management of testicular germ cell tumor in HIV. For the non-small cell lung carcinoma, next please. It appears to occur at a higher frequency at a younger age and present with more advanced disease in HIV infected patients. And in addition to the tissue diagnosis, a CT, chest, and abdomen is advised with special attention to the adrenals, along with the bone scan is advocated for the diagnosis of the non-small cell lung carcinoma. And interpretation of PET should be done keeping in mind the HIV load, CD4 count, and consequent possibility of the opportunistic infection in such individuals. operable lung cancer in HIV, it deserves curative surgery, and there is a high risk of complication and recurrence noted in the patients with HIV, especially when there are low cell count, CD4 cell count. Excuse me. So, if there is a locally advanced disease, chemoradiation is advised, and patient must be on ART and the appropriate OI prophylaxis before anti-cancer therapy is being administered. And metastatic disease must be treated with the chemotherapy alone. These tumors which are highly sensitive to EGFR targeting tyrosine kinase inhibitors like erlotinib and geftinib. This can be this is and being used in the treatment protocol, and the use of EGFR tyrosine kinase inhibitors, it requires caution due to the potential interaction with the ART through induction of cytochrome P450 isoenzymes, and there's no role of lung cancer screening in HIV as of now. For the hepatocellular carcinoma, and this is actually kind of there's a debate as to whether there is an increased incidence of HCC in HIV, primarily because of confounding influence of hepatitis B and C. So, Indian studies have documented HPV and HCV to co-infect 11 and 13% of respectively patients of PLHIVs, in contrast to 2 to 3% of non-HIV population. And ultrasound and AFP levels. This is actually being used as a diagnostic tool. A CT chest, abdomen, and pelvis is required to exclude a metastatic disease. And the degree of immune suppression, it does not appear to correlate with um, the staging of this hepatocellular carcinoma. Hepatocellular carcinoma patients with HIV tend to be actually younger and more often with HCV co-infection, and they are more likely to present with cirrhosis, and they're more likely to be on only moderately immunosuppressed due to the pre-existing ART, and likely to have a excuse they are likely to have a similar Barcelona clinic liver stage at presentation as compared to non-HIV infected individual. So solitary or a smaller number of HCC lesions are respectable, and complete resection is attempted in such cases if the Child-Pugh score is A. And liver transplantation appears to be superior to resection alone in HIV negative patients. And HIV seropositive does not appear to be a negative prognostic factor for transplantation. So protease inhibitors, these may inhibit cytochrome P450 enzymes and interact with the immunosuppressive agents. So it should be used with the caution. Sorafenib has been well established for HCC in HIV negative patients and appear to be equally effective in PLHIVs who are on antiretroviral therapy. Excuse me. And all HPV and HCV co-infected patients, they should be advised 6 monthly AFP estimation, even in the absence of the cirrhosis. So, immunological and virological criteria which are necessary for considering liver transplant in HIV-related patients are the amongst the immunological criteria. There should be no AIDS-defining opportunistic infection within previous year, and CD4 count should be above 200 or 100 cells in cases of the therapy intolerance. For the virological criteria, and if there is undetectable viral load in the last 12 months or effective therapeutic options for HIV infections during the post-transplant period are available. So alpha fetoprotein screening every 6 months should be offered to all cirrhotic PLHIVs and non-cirrhotic PLHIVs with the Hep B and Hep CV co-infection. Hepatocellular carcinoma screening with liver ultrasound should be offered to patients with cirrhosis or decompensated liver disease, and it should be treated in the same manner irrespective of the HIV status. HCC in PLHIVs may be treated with the liver transplantation if feasible, and sorafenib may be used as a treatment option in inoperable cases of the hepatocellular carcinoma. Next, please. Now, for the skin cancer, in PLHIVs, primary skin malignancies are the most frequent non-age defining malignancies. Risk is higher for developing a non-melanoma skin cancer, and the ratio of squamous cell carcinoma to basal cell carcinoma in HIV patient is 1 is to 7. In atypical features of HIV associated squamous cell carcinomas are presentation at a younger age, unusual unexposed sites, which includes mouth, genitalia, and perineum. There can be multifocal involvement, aggressive and higher potential for recurrence and metastasis. And routine clinical skin examination and self-surveillance of skin in older PLHIVs is warranted in those with a history of the skin cancers. Next, please. So, although conventional treatment protocols are acceptable for HIV-associated skin cancer, special attention to local excisional marginal control, more extensive investigation for dissemination of disease, and more intensive follow-up are mandated. And basal cell carcinoma and squamous cell carcinoma, these have been reported to remit with the antiretroviral therapy. Topical imiquimod. It has been used for treatment of basal cell carcinoma in PLHIVs and is useful for common scenario of multifocal superficial basal cell carcinoma. So recommendations are for behavioral counseling to PLHIVs with fair skin to minimize UV radiation exposure and reduce skin cancer risk. And counseling on frequent photoprotective behavior and sunscreen use is being done. Regular self-examination of skin and clinical skin examination and early treatment of pre-malignant lesion is important so as to reduce the skin cancer risk. Now, lastly, the penile precancer and cancers. So, despite ART, penile cancer is 5 to 6 times more common in HIV. Uncircumcised state, poor hygiene, smoking, lichen sclerosis, and HPV. These are the principal risk factors. And uncircumcised men with HIV should be counseled and questioned at diagnosis and during management about genital health and smoking. And so penile intraepithelial lesion and established penile cancers, this should be treated as per the standard guidelines with preventive and curative tissue conservation and sentinel lymph node biopsy occupying the central roles. And we should be recommending counseling about the genital hygiene and health, which is important to prevent such malignancies. And routine circumcision is actually not advocated for prevention of penile cancers. However, examination of genitalia and circumcision should have a low threshold. So this was all about the this talk. If there are any questions, please let me know in the chat section or you can ask me.
Thank you, ma'am. Participants are requested please unmute their mic and the question. No question in the chat box. I think there is no question, ma'am. I will quickly run the feedback form. Participants are requested please fill that feedback form. Yes, thank you all. Ma'am, can we conclude the session now? Hello, ma'am, can we conclude the session? Thank you all participants for participating in the session. Thank you all.